Okay, pause.
Of life. But the point that I would underscore, that the council would underscore, is that those relationships are all incredibly important for children's development. And there is something very unique about the relationship with biological dad. So we need to remember that as we're thinking about including fathers in the systems and the services that we provide. Because the way we parent is different. And so fathers play a unique role in their child's development. And it's very, very clear in the data: language development, social skills, understanding the guardrails, launching into separation from their families. So many of those outcomes are uniquely affected by dad's involvement. And we can tell you hundreds of stories where fathers' lives involved in their children's development and in the sort of supports around that family have had a profound impact on that family. And that doesn't mean that moms don't too. It means that we need to shift our thinking toward a more whole family approach. And I know we use that language, so don't feel like there is not an acknowledgement that we've made that translation in our language. But if we really stop and look at our services, I think we have so much opportunity yet to go. And that leads you to the last piece of this, why we're here. And that is that when this council came together 9 years ago, we did a environmental scan of what are the unique resources for fathers and father figures in our state. And it was horrifyingly thin on the ground. Very, very few folks who said they had unique services that were culturally unique services for men. And many of you are here. I see faces of people who are doing that great work, and that's fantastic. But what we saw was that we really need to focus on the fact that fathers should have those supports so that they can be the dads that they aspire to be. So thank you for continuing to introduce yourself in the chat. I'm going to monitor the chat, and I'm going to ask you if you could write your questions as you're thinking of them. And just to sort of give us a moment to pause and think about this topic. We have been talking about maternal mortality and the interface with the healthcare system around the time of birth for many, many years. We all understand the importance of early development, early relational health and wellness in a family. All of that is embedded in this conversation today, but this is a tough one, and it's a tough one on multiple levels. One, that we're talking about the loss of a parent at birth and the surviving parent's life and impact because of that, and the child's impact because of that. It's also just very, very dense. There's a lot of material here, and it's going to come by fast. So because there's a lot to cover, a lot of ground to cover. So please do put your questions in chat. And if it's something that's really time sensitive, you know, oh, Nathan, good to see you. A specific clarification or issue that you want to dive into, we'll stop right there. We'll grab that question and we'll deal with it. Otherwise, we'll wait till we get done with the first section, which is coming from our friends at the Public Health Department with the general population, and then the second section, which is focused on our Indigenous population. Oh, good to see so many familiar faces. I'm so glad that you're all here. So want to shift us to the next one, Marilyn? So then the next thing that we want to make sure that we share with you is that because the state budget cuts eliminated the staff for the Washington Fatherhood Council at the Department of Social and Health Services, we have our wonderful friends at the Department of Children, Youth, and Families who are with us here and are supporting the continuation of this series. So Marilyn Gisser is here, and she's going to be doing this work as the lead at DCYF around the Provider Learning Series. But one of the things that that means is you haven't seen us for a while because we've had to go through this transition of sort of distributing some responsibilities for the council. But also there is no director anymore, and there is no full-time staff anymore on a coordinator level like I did and like Dieter did. So it's going to be a little more gap between. We're targeting every couple months for the provider learning series, but there is a really strong commitment to keep the work moving forward. So just as you've done in the past, please, 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 and now is even more important than ever, fill out the evaluation and let us know what you're thinking about in terms of upcoming topics. And please go back to the website if you're interested in learning more about the fatherhood work and look at the old provider learning series topics and say, oh yeah, we already did that one. Maybe I'll go catch up and use this with my staff, or maybe I'll go back and learn this information and then ponder where to go from here, because there's a wealth of information there. We've done many, many really, really thought-provoking conversations. So I'm going to introduce our amazing presenters who have been in this conversation about how to present this to you for many months. Deborah Gardner and Annie McHugh are going to be doing the findings and the recommendations from the Washington State Maternal Mortality Review Panel. And I'm not modeling this well. Deb's about speaking more slowly. Sorry. I'm racing so that you can go, but this is a really deep topic that I want us to make sure we're not speaking too quickly. And then our friend Cindy Gamble from the American Indian Health Commission to talk about this data as it relates to our Indigenous population. So please do put your questions in the chat. Welcome. We're so glad you're here. And Debs, I think you're first, right?
Yeah, thank you. So I'm Debs Gardner. I'm the Maternal Mortality Review Coordinator at the Washington State Department of Health. I have the honor of working with the Maternal Mortality Review Panel. I'm presenting today from home in North Kitsap County on Suquamish land. And I saw there were several other Kitsap people here today. Annie, do you want to introduce yourself quickly too?
Yeah, my name's Annie McHugh. I use she, her pronouns. I am the epidemiologist that supports the MMR work at the Department of Health.
Okay, I'm going to say one more quick thing, which is not I'm not meaning to point fingers, but we have to be super, super careful when we talk to a group that's this diverse about any alphabet soup. And I know that MMR, now we have maternal mortality review up on the screen, but that's one of the things that helps people really follow us is if we spell everything out. So thank you for reminding me, Annie. I forgot to say that.
Yeah, no problem.
No sweat. Thanks.
Thank you. So before we get started, I want to take a moment to honor all of the individuals, the families, and communities that are impacted in any way by maternal mortality. And this very much includes the dads and other non-birth parents and family members left behind who carry this grief in their hearts and often also in their journey as parents or other relatives. We also acknowledge that all of the social structures and histories that contribute to these deaths are really challenging, and that this is a really difficult and emotional topic. It illuminates some aspects of our work and our world that can be quite disturbing. We recognize that when people die during and after pregnancy, they really leave a hole in the hearts of the families and communities, and that may not always heal or heal fully. And for many communities, this just can't be put into words, let alone described in data or in a report. So we do this work so that we can learn and try to work together to prevent these kind of deaths in the future, and also improve perinatal, maternal, pregnancy, post-pregnancy care for everybody. And we share what we learn with partners and community members like you so that we can begin to figure out how to accomplish this, how to undo some inequities and improve the well-being of individuals and families. So thank you for making time for us today to share what we have learned with you. So I'm going to give a little bit of overview and background about Washington's Maternal Mortality Review Panel and report. So maternal mortality review actually happens all around the country. Most states and jurisdictions across the US have some work like this, and most of us actually receive CDC funding as of now to do this. All those dark blue states receive CDC funding. The ones that are lighter blue also do maternal mortality review. You can see that there's some places like Texas that do not currently do this work. In Washington, this work actually comes with a legislative mandate. The legislature established the Maternal Mortality Review Panel, or MMRP, in 2016 following the enactment of a Senate bill. And you've got the RCW up there on the screen. You can also just Google it and find it if you want to read the details. In 2019, the law was amended to make the panel permanent and to add some details to the review process. And the law directs us to conduct comprehensive reviews of deaths of Washington state residents anytime during pregnancy or up to 1 year after the end of pregnancy. And we're going to talk a little bit more about what that looks like. So this panel is convened by the Washington State Department of Health, DOH. Last term, when this report covers, we had about 80 members. We actually have about 100 now. Not everybody comes to every review meeting. We have quite a breadth of expertise and backgrounds, including a real priority focus on American Indian and Alaska Native communities. And this panel reviews these anonymized, de-identified summaries of each death of Washington residents in that time period that I mentioned through 1 year after pregnancy. And then about every 3 years, we give a report to the legislature, which is what we're going to be talking about today. So I mentioned that breadth and wealth of expertise, and this is just some of the expertise areas, everything from knowledge about Indigenous lactation counseling to maternal fetal medicine, lived experience, people from state agencies, people who know about nutrition, medical emergencies, substance use disorder, and just the list goes on. We are very lucky in Washington to have the expertise range that we do. So I want to talk about some definitions that are going to help all of this make a little more sense. Sometimes we use this term pregnancy-associated deaths, and that just means it's about the timing. Any death that happens from any cause whatsoever that happens to be during pregnancy or up to 1 year after. And pregnancy-associated deaths covers it whether or not the death was related to pregnancy. So then a subset of that are the pregnancy-related deaths. Those are deaths that are in some way caused or worsened by some aspect of pregnancy. So these could have happened because of, some of the straightforward things like a pregnancy complication or a chain of events that was actually initiated by some aspect of pregnancy or postpartum. But it also includes deaths that were from an unrelated condition that in some way was aggravated by some aspect of pregnancy, which includes, birth and postpartum as well. And then there's also some pregnancy-associated deaths that aren't pregnancy related. The cause didn't have any connection to pregnancy. And occasionally there are deaths when the panel just doesn't have enough information to determine if the death was related to pregnancy. So this review process, like I mentioned, the panel uses a very anonymized, de-identified case narrative summary. They don't know who the person was, where they received care, even what county they were in. And they discuss to say, well, did they think this death was pregnancy related? Was it preventable? And they ask not just was it preventable from like a medical clinical perspective, but also an equity or social determinants of health perspective. Did the questions like whether racism, discrimination, and bias played a role? What factors contributed to those preventable deaths? And then once they've understood those factors, they say, okay, well, let's make recommendations. What kind of interventions or systems changes might help prevent deaths like that in the future, even if it happens years before, way upstream, or at the moment of intervention. And those actually become the basis for our legislative report every 3 years. We prioritize among those to put in the report, and we'll be giving some examples of those today. So I mentioned the report. I'm going to put a link directly to the PDF of the report in the chat. It's also available from this QR code on the screen. Some exciting news is that this report actually went to the legislature, its official destination, 2 days ago. So you're the first audience to hear about the report since it went to the legislature. We did offer some preview information about it, but this is new and exciting news. The aims of the report are obviously to prevent maternal deaths, to raise awareness about what factors contribute to these deaths, to promote change, to increase health equity, and to improve perinatal care across the state. This report includes new data from 2021 and 2022, and also some like demographic, for example, cumulative findings from 2014 through 2022. And we're going to give you a glimpse of those today. It includes recommendations that come from those reviews I was talking about. And some of the recommendations are for the legislature and some are for other audiences, including everybody on this call. And then the report includes an addendum from the American Indian Health Commission that Cindy Gamble will be talking about later today. So, if some people might have been familiar with our past reports, there are a couple quick new things with this report. It's a little shorter, more focused. There's a bit more focus on a legislative audience. It has some voices of Washington, voices from Washington, personal stories about things like pregnancy, birth, and postpartum experiences and challenges in Washington. It also has some success stories about past recommendations from the last report, and actually also a list of legislative accomplishments and budget measures that relate to the last report. So I'm going to turn it over now to Annie to talk about our data and findings in this report.
Thanks, Debs. All right. So before we dive in, there are a few important considerations to keep in mind. First, maternal mortality is a relatively rare event. This means we're often working with small numbers, which can make rates unstable, especially when broken down by specific demographic groups. Additionally, Washington state maternal mortality data is not generalizable and should only be interpreted within the context of our state. But with that being said, even with these limitations, we can still utilize maternal mortality data to make meaningful recommendations and interventions. The United States has the highest maternal mortality rate among wealthy countries. In the next few slides, I'll provide national and state level rates. They won't be shown together because the national definition of pregnancy-related deaths differs from Washington's definition. That key difference is the national rate doesn't include injury deaths such as homicide, suicide, and accidental deaths, which include accidental overdose. Here we have the national rates of pregnancy-related mortality from the Pregnancy Mortality Surveillance System, otherwise known as PMSS. We can see a noticeable increase in maternal mortality rates during 2020 through 2022 compared to previous years. Research has linked the rise experienced in 2020 and 2021 primarily to COVID-19. The increase was driven not only by the direct impact of the virus, but also by COVID-19 exacerbating existing health conditions and disrupting access to care. Although it's not shown on this slide, national maternal mortality data also highlight disparities by race, ethnicity, and age. Here we have the Washington state rates from 2014 through 2022. As we defined earlier in the presentation, pregnancy-associated deaths is a broad overarching category that includes any death occurring during pregnancy or within 1 year after pregnancy. So the dark blue line is accumulation of both the pregnancy-related rate, which is the light green dashed line, and the pregnancy-associated but not related rate, which is the light blue dashed line. Washington's pregnancy-related mortality rate peaked in 2021 at 33.4 deaths per 100,000 live births, followed by 27.6 in 2022. These are the highest rates observed in the 2014 to 2022 period. This increase in pregnancy-related maternal mortality is likely due to several factors. First, a rise in overdose deaths, particularly involving fentanyl, which has become more prevalent and deadly. And second, deaths related to COVID-19. And finally, the Maternal Mortality Review Panel has continued to evolve their process for deciding on pregnancy relatedness, which can impact the numbers of pregnancy-related deaths identified. So let's take a closer look at maternal deaths in Washington in 2021 and 2022. For those years, we identified 107 pregnancy-associated deaths. And then focusing on the second row, you can see starting from the right, 46 of the 107 pregnancy-associated deaths were determined not to be related to pregnancy. For 10 cases, it could not be determined, and that leaves 51 deaths that the Maternal Mortality Review Panel determined to be pregnancy-related. Of the 51 pregnancy-related deaths, 42 were considered to be preventable. So as we just saw in that last slide, the panel found that 82% of pregnancy-related deaths are preventable, meaning there was at least some chance of the death being averted if a clinical, equity, or social determinants factor that contributed to the death had been different. 82% is very high. However, this means we understand preventability and can take action. Inequities and disparities persist in pregnancy-related data in Washington. In the next slides, I'll provide cumulative findings from 2014 to 2022 and discuss, depending on race, and age, race, and ethnicity, geography, and insurance status, the rate of maternal mortality rates differing. The graph on this slide and the following demographic breakdowns will provide frequency of pregnancy-related deaths in dark blue, which tells us the actual burden or volume of pregnancy-related deaths, and rates in light blue, which provides the frequency relative to the size of the population or subgroup, allowing for comparisons between groups of different sizes. The rates include confidence intervals, which is important because the confidence interval quantifies the uncertainty around these estimates. Additionally, if a subgroup is marked with an asterisk, this means that the rate has a relative standard error that is greater than 25% of the rate itself, which indicates the estimate is statistically unstable and should be interpreted with caution. So for this breakdown of age, pregnancy-related mortality occurred most frequently among individuals aged 30 to 34, followed by those aged 35 to 39. Although individuals aged 40 and older had the fewest pregnancy-related deaths in terms of absolute numbers, they experienced the highest mortality rate, which reflects the fact that while fewer people in this age group give birth and fewer die overall, their risk from dying from pregnancy-related causes is disproportionately high. These findings highlight the risk of pregnancy-related deaths increasing with age, especially for those over 40. Non-Hispanic American Indian and Alaska Native people experienced higher maternal mortality rates than any other racial or ethnic group. Although the absolute number of pregnancy-related deaths is low, the risk of dying from pregnancy-related causes is 7.3 times higher than that of non-Hispanic white people, which reflects an alarming disparity and is why we have an addendum to the report from the American Indian Health Commission, which you'll be hearing about after this presentation. Additionally, non-Hispanic Native Hawaiian Pacific Islanders, non-Hispanic Black, and non-Hispanic multiracial individuals experience high rates of pregnancy-related mortality. When we look at pregnancy-related mortality by an individual's primary insurance, people with Medicaid experienced both the highest number of pregnancy-related deaths and the highest mortality rate at 36 per 100,000 live births. These figures highlight the critical importance of ensuring access to quality care and support through the perinatal period for individuals covered by Medicaid, especially since Medicaid is usually serving as a proxy for various social determinants of health, such as income, housing, stability, access to basic needs, etc. Lastly, we will look at pregnancy-related mortality by rural or urban residents. Although 122 pregnancy-related deaths occurred among people living in urban areas, the overall mortality rate was highest among people in rural areas at 26 per 100,000 live births. This underscores the importance of improving access to quality maternal health services in rural communities. Now that we've looked at how pregnancy-related mortality varies across different demographic groups, I'm going to shift our focus to understanding why these deaths occurred, and we'll explore causes, timing, contributing factors behind these pregnancy-related deaths. This will help us see the bigger picture of challenges faced and where the interventions might make the greatest impact. Looking at pregnancy-related deaths from 2021 and 2022, the top 5 leading causes of pregnancy-related deaths were accidental overdose, COVID-19, suicide, and cardiovascular conditions, including peripartum cardiomyopathy, and also thrombotic embolism. These causes highlight a mix of clinical, mental health, and social challenges that contribute to pregnancy-related mortality, underscoring the need for comprehensive approaches to prevention and care. Most pregnancy-related deaths occurred within 43 days to 1 year postpartum, followed by deaths within 42 days of pregnancy. These findings underscore the importance of care, support, and health insurance coverage through 1 year postpartum. The panel identified contributing factors that led to each preventable pregnancy-related death. These factors are defined by the CDC and are events or circumstances that, if different, the panel believes might have prevented the pregnancy-related death. So in the graph on the left, you can see that I'm representing the top 12 contributing factors. I'll quickly highlight the top three, which were lack of continuity of care and or care coordination, lack of access to care or financial resources, and clinical skill or quality of care. For each identified factor, the panel made recommendations to prevent future deaths. Those recommendations are going to be discussed in detail by Debs. Before we move on to recommendations, it's important to highlight that the panel found discrimination, bias, and interpersonal racism or structural racism played a role in 76% of preventable pregnancy-related deaths from 2021 to 2022. This emphasizes the need to center Black, Indigenous, and other communities of color as leaders in the successful implementation of many of the recommendations shared in the presentation and in the full report. And I'll hand it back to Debs.
Thank you so much, Annie. So I'm going to talk about some of the recommendations in this report. So again, here's the QR code for the report, and I'll put the link for it again in the chat. So we organized all of the recommendations in this report under three kind of umbrella categories, our priority recommendations. And under those, there's 12 recommendations for the legislature and 75 for other audiences. And this is important because I'm going to give you some examples today, but this is in no way comprehensive of all of the recommendations in the report. And even a couple that I mentioned for the legislature, I'm going to give you kind of the short beginning of those, many, many details under them. So you're going to want to look at the report as a whole to see more details on these recommendations. The other audiences, there's a couple examples here, but it is actually quite a bit broader than this as well. So those three priority recommendations, we're going to delve into each one of them. But overall, the first is to improve healthcare quality and access. The second is to strengthen community support services. And the third is to provide equitable, culturally responsive care. So let's look at that first one, improving healthcare quality and access. And this is to ensure Washingtonians have access to high quality healthcare, which includes mental health care and substance use disorder treatment, preventive care, and that this should be throughout pregnancy, birth, and postpartum. And the goal is to do this by strengthening and funding care coordination, improving communication and protocols, ensuring providers have the skills and training and professional support they need to provide high quality care. And again, there's going to be many sub-examples of this. So why healthcare quality and access? This seems pretty straightforward, but the report gets into a lot of detail about why we've selected each category of the recommendation and why it matters so much. So when you just look at our data, reflecting what Annie just showed you, of those 5 top causes of the pregnancy-related deaths, 3 of them were actually primarily medical, so COVID-19, cardiovascular conditions, and embolism or thrombosis. And then the other 2 of the top 5, which were accidental overdose and suicide, they also had clinical components, both in how you prevent them and how you treat them. So healthcare quality and access really matters for what we're actually looking at in these data in the report. And as Annie showed you, those contributing factors to the pregnancy-related deaths, those included specifically things like access to care and, to the pregnancy-related preventable deaths. Those included things like lack of access to care and care coordination, care continuity, and all sorts of other things that are specifically about healthcare quality and access. We know that limitations in the healthcare system worsen maternal mortality. So there's a lot of factors like barriers to access to care that matter here too. So a couple examples of the recommendations in this category. So one is for the legislature that it should protect and increase funding and access for family-friendly, judgment-free substance use disorder treatment and opioid use disorder treatment for and support for people who are pregnant and postpartum. Also, that the legislature should support policies and provide financial support to address the shortage of maternity care and emergency obstetric care in rural areas. There's also a recommendation that hospital systems should provide training and develop policies and procedures to ensure that providers and staff, including emergency department and urgent care providers and staff, know how to recognize, respond to, and manage pregnancy-related emergencies across settings. These are a couple examples. Again, there's many, many more. So then that second priority recommendation, this is about strengthening community support services. So this is about investing in, developing, and expanding comprehensive community support services that address essential needs in pregnancy and postpartum. Things like home visiting, social work, doula support, and wraparound support for mental health and substance use disorder. So why this topic? So, for example, nearly a third of the pregnancy-related deaths were among people who faced housing instability or were unhoused. And of those, half were associated with substance use. And lack of access to protective social and environmental factors, things like housing and food and thriving neighborhoods and education, we know that these affect health. And all of these stressors, these are connected with stressors and detrimental factors like systemic racism and health system complexity. And all of this is even more pronounced in pregnancy and postpartum. It's at the root of a lot of maternal deaths, including overdose deaths. But we know that support services help this step, things like doula care, and home visiting, and things that can reduce barriers to substance use disorder treatment. So a couple of the example recommendations under this, there's one that the legislature should expand support for universal access to wraparound services through pregnancy and at least 1 year postpartum. It includes home visiting, doula support, peer support workers, that the legislature should prioritize both protecting existing funding and also providing new funding and programs to meet people's basic needs in pregnancy and postpartum, things like transportation, housing, income, and childcare, to make those universally available. It's also a recommendation that funding and state and local agencies should, funders and state and local agencies should increase funding and capacity for community-based organizations to support people in pregnancy and postpartum, including culturally relevant services. So the third category, providing equitable, culturally responsive care. This is about ensuring that care and services throughout pregnancy, birth, and postpartum are culturally relevant. They're free from bias, grounded in trauma-informed practices, and actively address racial injustice. And the reasons for this, so like Annie mentioned, discrimination, bias, interpersonal racism, or structural racism contributed to over 3/4 of these preventable pregnancy-related deaths in these 2 years. And we saw the racial and ethnic disparities in the maternal mortality rate, as well as among rural communities and people covered by Medicaid. We know that inequities, bias, and structural racism and violence contribute to maternal deaths. And actually, research shows that if you don't address those kinds of issues, other efforts to reduce maternal mortality are going to have a limited impact. And we know also what works. We know culturally responsive care that reflects people's cultural needs and counters bias can change these situations, can prevent discrimination, build trust, and deepen cultural connections. So a couple sample recommendations. So there's one that healthcare systems, state agencies, and academic institutions should work together to build and sustain a diverse maternal health workforce, and it should reflect the communities it serves. That DOH and Department of Health and Healthcare Systems should fund tribal-led, indigenous-led, and community-led efforts to expand access to prenatal and birthing care in American Indian and Alaska Native communities, including in rural areas. Also, health systems and providers, that they should offer compassionate, respectful care for people with substance use disorder and opioid use disorder, that these are not influenced by bias. And then that DCYF and partners should provide proactive, community-based resources to help families stay together safely and to strengthen relationships between children and their fathers or other non-birth parents. This includes things like offering culturally relevant parenting support and addressing barriers such as incarceration, poverty, CPS involvement, as well as expanding access to early voluntary services to support families during pregnancy and postpartum. So there are some current context and emerging challenges. I do see the question in the chat, and I think we can address that maybe at the end. We can't talk about specific cases, but we could talk broadly about like why this might be an issue. So there are challenges to meeting these recommendations, and there's issues at the state and the national level. So nationally, we're looking at pending significant cuts to Medicaid. Medicaid covers 45% of births statewide, and in rural areas, that's 70%. There's growing shortages of rural maternity care. There's challenges and fears about perinatal and reproductive care access. There's barriers to mental health care access, state budget limitations that impact funding. There's not only access, but also disinformation challenges around vaccine support. There's threats to immigrant, BIPOC, and LGBTQ communities, among others, and uncertainty about all sorts of future circumstances. And this means that it's particularly important to work on these recommendations and also challenging. I want to talk very briefly about implementation work on this report. Implementation happens, well, let me step first and say implementation happens in all sorts of ways. Somebody on their own, working for maybe a community-based organization, referencing the report in a grant application, that's implementation. A group of doulas saying, oh, hey, let's do this change that, we see this in this recommendation, this resonates with us. That's implementation. There's also some centralized work, like the Washington State Perinatal Collaborative. And I think my colleague, Tiffany Tibbs Christensen, is on this call as well, who works with that collaborative. And this is kind of the implementation hub of MMRP recommendations that leads some projects to implement the recommendations, and also amplifies other efforts happening statewide, including some of the things that you might be working on. And this is just a glimpse into some of the many different types of projects that they lead or support. And I think the Perinatal Collaborative is always looking for more folks to get involved. But I want to bring it back to this audience and say, how do you connect the MMRP recommendations to your priorities? And this is relevant to everyone from decision makers, people who work in healthcare and public health and everything related, and dads and other family members. Everybody plays a role in helping prevent maternal mortality at any level, from the systems and structural to the individual. And so as you spend time with the report looking through, thinking about which recommendations are most relevant to dads and other non-birth parents, how can dads and other non-birth parents raise awareness of maternal mortality at any level, again, from like large scale to individual? How can the reports, if you're working on things that are connected to issues in this report, how can findings and recommendations in this report support your work and your priorities? How can this further what you're doing and what you want to do? If you're involved in efforts already to implement one or more of the recommendations, or if there's something that you want to start soon, how can this report bolster your efforts? Are there others that you want to collaborate with and say, we would like to do this, but we really need folks who are working on this. Are you interested in working together with us? So we want to kind of spark some conversation about that. I don't know if we have time for a little bit of chatting. Do we have a little bit right now?
Yeah, let's do that. Let's take some time to unpack this a little bit. So I just want to make sure that we've addressed sort of the little side conversation around that Kyle sort of
Uh,
sparked around drug use. And
I
I
want to,
think
I'm
it's
sorry,
been answered, but I'd love it if you could do a little bit more context around that.
I want to actually, so something that I learned in the course of this work that I didn't know about was, so some of the overdoses that might be pregnancy related, and I've heard about this kind of nationally. So somebody who was dealing with substance use, let's say prior to pregnancy, I'm not giving any particular example here. This is sort of a theoretical thing. And somebody said, this is how it can work. It was very interesting to me. So let's say somebody dealt with substance use prior to pregnancy and was able to stop using during pregnancy. And then for whatever reason, whatever life stressors or circumstances, they started using again at some point in the postpartum period. Their tolerance might have changed, and what might not actually have led to an overdose when they had a higher tolerance might now lead to an overdose. I've always thought that example is fascinating because it's a great example about how an overdose might be both pregnancy related and unintentional. So I hope that that helps.
Yeah, and thank you to those who are in the field that are responding to help further clarify around street drugs as opposed to dispensary, and what does this look like in the real world. The other part of this that has come up quite a bit in the last few years are services that have historically been maternal dyadic focused, that folks are trying to expand to be more inclusive of fathers' roles. And so while we're on the drug and alcohol and SUD issue, maybe we could tease that out a little bit and get people thinking about that a little bit more. And Ashley, I think I just saw you pop in, but one of the issues that we hear a lot about is that there, I believe I'm saying this right, and Ashley, you're gonna correct, well, actually, if you could just open your mic and maybe just expand on this. But one of the things that we know is that there are a dearth of um, inpatient treatment facilities that allow dads to be with their kids. So one of the things that we can't probably tease apart in this report is where these are cohabitating or non-cohabitating parents, right? We don't know if these are folks that may have separate living situations, but may both have issues that they're struggling with. Um, so Ashley's been really involved in opening up a family treatment center. And Ashley, can you access your mic and can you share what you guys know from the Healthcare Authority about this part of the work?
Yeah, so a part of my role was to launch a facility, an inpatient program that was inclusive of couples as well as fathers and mothers. What we know right now and what we have available are residential treatment facilities that serve pregnant and parenting women and their accompanied children under the age of 6. In Washington State, we do not currently have any residential facilities that offer services to fathers and their children. So, part of my work was to develop a family preservation model inclusive of fathers that could be implemented within a residential treatment facility. Unfortunately, despite our efforts, that was not able to launch, and that's due to many layers. So, the work continues in of advocating for and building out family-centered services that are inclusive of fathers because there is a need. And if you look at the data tied to DCYF in terms of out-of-home placement for children, one of the primary factors that contributes to that is parental substance use. So there is a need in Washington State.
Ashley, that's heartbreaking to hear. I hadn't heard that it didn't actually go forward, but your work and your uh, championship around this has been extraordinary. And so we know that that will continue, but this is a place where people really need to be expressing their opinions to folks who have resources around treatment and treatment services. The other one that we've put a lot of time and energy around and people have been thinking about quite a bit is the PCAP services. So that's the Parent Child Assistance Program, which was a model that was supported by the University of Washington. And it had been under pretty strict research guidelines, but those were completed a couple years ago. And so there have been folks who have been trying to expand the focus of PCAP to be inclusive of fathers, so that, in other words, dads could receive those in-home supports, those intensive in-home supports around SUD recovery in relationship to their children. And there haven't been any of those funded yet. And so I think when we think about the translating this into the world of fathers, it usually just takes that one extra step around what could it look like if we were sort of not repurposing, but more inclusive and thinking about ways that we need to either raise awareness or plant seeds that might increase the likelihood that fathers may have access to this work as well. Other questions and thoughts about SUD, I would welcome you to jump in and posit those in the chat. And while you're doing that, I'm just looking at the list here and I don't see any of our dad doulas, but one of our dad doulas came into the work because of a very, very difficult birthing with his first child. And after a very difficult and long labor, it finally went to a section, but his reflections on it are actually quoted in our State of Fatherhood report, where he talks about the fact that they had a plan. They went in as a team. They were really excited about the fact that they were doing this in a very supported partnership. And he felt like at the point that he signed off for the C-section, that he said no one had ever addressed him, no one had included him, and he felt like he had let her down, he had let the process down, he had let his child. I mean, he just left it with a lot of big feelings and guilt and frustration and feelings of helplessness and hopelessness that they didn't see him as part of that team. And so one of the other things that has shifted in our environment in the last year, which is super positive, is the doula certification and the doula um, opportunity for reimbursement using Medicaid dollars. And I don't know about private insurance. Um, but from what I know from the dad doulas across the state, and we only have 5 that I know of, there may be more, is that they attended those meetings, but when it came down to policy, it was the dad reimbursement was excluded. And so there's an exciting piece of that around that the report helped strengthen that support around families, but there's an opportunity there, it sounds like, for voices to still be raised around the roles that dads play, whether they're cohabitating or not. And if they're not, what are the struggles and challenges that presents? Does anybody have any thoughts about the doula, the whole process? And maybe before we go with that, I think the SUD thing is still really rumbling. So maybe we need to hang with that a little
I
bit.
mean, I think people are engaging with that in the chat, and I
You're
would love to.
dealing with it. Okay. It's more where are their services? And yeah, I see that. So anybody have any thoughts, or can you guys share about the doula certification process and any ways that you think that may be sort of a process that the council might get involved in over the next coming years? Because it really feels like that is intentionally um, supporting the whole family in a way that um, helps fathers strengthen their role, feel confident in their role. Because what I hear from the dads that have struggled with that is I didn't know what to do. I didn't know what to say. I didn't know how to relate to the process, and I wasn't included. And then they walked away feeling the biases were working against them, and they didn't do what they wanted to do, that they felt like they weren't um, contributing in the way that they wanted to. Does anybody have a thought about that? And Ashley, is this enough of your world that you know about the process of the doula certification, or is that too far afield from what you've been doing?
It's not in my wheelhouse, but I will put the contact person in the chat who can answer any questions and who's also somebody to connect with on after pregnancy coverage, if that is also a topic of interest.
Oh, actually, Napuna, am I saying your name correctly at Parent Trust? Can you jump in? Because you guys have been super involved in this work.
Hi.
Hi.
Not sure. I am a doula and I run the family helpline, and I am not on the Doulas for All group, but it is tied to the Medicaid benefit for the birthing parent. But a birth doula is supporting the parents. So a non-birthing parent cannot access that doula support unless they are with the birthing parent. Is basically how it works.
But does that mean that the way the billing structure changed, that 2 doulas could be reimbursed, or is it still just the birthing parent and that parent and that
Just,
doula would support both?
yeah, it's just the birthing parent doula. It's a birth doula, but the model for doula support is to support the parents who are having a child.
Right. I
So
do.
the
Yeah.
doula is there to support the non-birthing parent as well.
Right. I do understand that. And then as I listen to men talk over many, many, many years, the opportunity for their individual support from that unique perspective, they're saying that that would be a huge plus in their ability to be feeling more confident in that process. So just positing it as a place where maybe the council may be able to add more energy to that. And Jose, I see you're kind of jumping in. What, and you've had different birthing experiences with your two kids, but I don't think you used a doula either time, right?
So I don't know if this could be a kind of moment to encourage some. Oh, I'm sorry, we're waiting for a spoken response to that.
I was just wondering if, Jose, if you had any impressions in that, and then, yeah, Debs, if you have other thoughts about teasing out some of these recommendations.
I don't just
Anything you want to
hopefully didn't
add?
hear me. Yeah, just highlighting the importance of maybe including um, the dad at every stage, and maybe what Anne might have been referencing more of carved out programs that are for dads. For example, some of the mental screening services that are offered at OBGYN clinics are only offered to the one billable client at that time, where we know that a lot of breastfeeding support is surrounded by, if you include the partner, and we also know a lot of SID prevention when they are included from the very start. And
Yeah. Nipuna, a thought?
I just wanted to bring up something. The birth doula Medicaid benefit does include some postpartum hours, and I feel that there's room there for policy change or adjustment for providing that to the non-birthing parent.
Ah, thank you. And as we create these health information exchanges and these community hubs with Medicaid dollars, how are we talking to or working with the ACHs or the hubs at the local level around that issue? Because you just touched on one where there may be some local conversations where that could be explored. I'm guessing. That's really cool. Any other thoughts about this piece of it?
Yeah, I kind of want to bring people to the questions on the slide. These have been some, great examples so far of ways that people's work might be connected to the recommendations in the report. But if anybody is thinking of, maybe wanting to collaborate or network with somebody else, there's something that you've actually wanted to get started on or are already working on towards one of these efforts, and you're hoping to connect maybe with other people who would be on this call to collaborate on it. Or if you're a dad and you're thinking about, here's how I might actually raise awareness about maternal mortality because this has changed my understanding of it. Is there anybody who wanted to just share something so that you might be able to connect with other people on the call to further some aspect of this work in a way that's relevant to you?
Hi, everyone. My name is Nathan. I do one-on-one peer support through Perinatal Support Washington with dads. And I just wanted to jump in here because I've actually, this is a very I was recently reached out to by a doula who's looking to support a father who's going through maternal mortality through a mom dying right now. And I am not aware of groups, support groups locally here in Washington State or regionally that support dads who've gone through, who've had a partner or a spouse or their child's parent, mom die. And so I'm curious to know if those exist, if folks in this panel, in this group, know of specific efforts to support the surviving parent in these situations. And if not, I'd be interested in collaborating with other folks who do, especially support group work with dads to find out ways that we can to build a support group or a network of support groups to support the dads or co-parents in situations where the birth parent has passed away.
That's an amazing idea. It sounds like there's some requests in the chat for you to share contact information. I don't know of any kind of formal support group that's Washington specific about that. I know a researcher in another state just recently reached out saying, do you know if there's a way to, I think specifically connect with dads, and we don't directly. All of our work is completely anonymized, but I would love to see that happen. And yeah, I hope you find other folks to work with on that. That's wonderful. And
And
yeah,
Michelle, can I ask what part of DCYF?
I'm child welfare,
Child
so
welfare
I'm
side.
the
Okay, thanks.
engagement program
Super.
manager for child welfare, and fatherhood is my one of my roles.
That's
Um,
cool. So are you one of the liaisons to fatherhood at the regional level, like Sean who's on the call?
no, I'm a
Different role.
statewide lead. I'm a statewide
Oh,
engagement program manager.
oh, you're okay. You're the new person
Yeah,
that was
yeah,
yeah. Okay.
yeah, yeah,
Awesome.
that's
That
some
is
beautiful
really
collaboration.
exciting to think about.
yeah. And we're working on an HPSO flyer for moms, dads, and birth to three to kind of target. I'm on a work group around that to target that um, sort of group of folks. And I know that one thing I was thinking is that Nathan would be a good person once we kind of have a template or something to run that by Nathan potentially, and or he might know some folks that might want to look at that. But I can just think of lots of ways to engage with lots of folks
Yeah,
um, that are here today. So
that's exciting. And
That's
yeah.
some,
Kyle, hold that thought. I see
oh,
your hand.
I was just
Go ahead.
I was just going to say that's some beautiful collaboration. And I hope we see more of that. I don't know if, Anne, we need to move on to Cindy or not. I don't know where we're at
Yeah,
in
just
time.
one more sec. And
Okay.
yes, Cindy, we're going to switch gears here just in 1 minute. The
Okay.
other one, Nathan, that you didn't mention was the possibility of a collaboration with some individuals that are thinking about, um, I'm going to get this wrong because I used to call it peripartum mood disorders, and now it's postpartum anxiety and depression. I get it wrong. What's
It's
the
always an alphabet soup. Perinatal mood and anxiety
Thank
disorders.
you, PMAD or something.
Yeah.
Right. I'm old. I'm old. Thanks, Jenny. I should learn this. But we were talking about the idea of doing some piloting in a couple primary care sites around the idea of the fact that we now have the ability to bill for multiple screens at a primary care visit in that early bright futures periodicity that happens in primary care, and that postpartum period, the referral would go directly and could go directly to Nathan, um, to that resource around, once providers find a challenge, they're loath to identify something they can't do anything about. But we already have this wonderful built-in resource with the perinatal support line, and how could that become a way of um, dealing with identifying more dads that are struggling in that postpartum period. And we know that if mom is struggling with depression, that dad is 10 times more likely to have issues as well. And how might that contribute to that suicidality and completion that we're seeing in this report? Just wanted to pop that in there. Kyle, you've got a quick question that can't go in the chat?
Yeah.
Okay, go ahead.
So the question is that since 2018, 972 million plus dollars have gone to women and infants and children, and a total of 155 million has gone to fathers' rights or fathers' resources and things like that. And so you're asking us to help you and support you when there's almost $1 billion of support there for women in areas like this and limited resources. That answers Nathan's question. When 90% of the resources go to women and children, how is it that we as fathers can help you when we're not allowed to, in most parts, be active, involved with our children in life anyway?
Thanks for sharing that question, Kyle. And I just also want to recognize a lot of the really just the challenging experiences of dads, particularly dads who feel like closed out from parenting experience or supportive resources. I think whenever I hear about a question saying, there's already more funding for this, but what about less funding for that? I look at it like it's not a zero sum game. Money, like there does need to be more money to support dads in so many ways. And I think like some of the collaboration ideas in this meeting are highlighting that it doesn't need to come from other money that is also providing necessary support to save lives and improve perinatal care. We're all in this together. And yeah, any situation that sort of like pits important causes against each other, like I think we sort of need to stand shoulder to shoulder and say, actually, all of this matters and all of this needs support. And, sometimes it also, we're trying to figure out the best way we can overcome some of these barriers, and it's challenging, and we just need to work together. So thank you for voicing that, and I hope we can kind of share a message of let's not have one cause ever be at odds with another. And I think the other reason for that is I see all of these issues as really intersectional. Like to solve, like maternal mortality is an enormously intersectional issue, which is why the report covers so many different recommendation areas. And only focusing on one is never going to solve it. We have to come at this from all angles, and supporting dads is one of those angles. So thank you for bringing that up.
Thanks, Debs. Yeah, and I would also just add, Kyle, that as you know, because you've heard me say this so many times, we have never as a council thought about it as helping support one parent over another. It has never been the conversation. It is really about how do we rethink how we're supporting families holistically. And that means sometimes turning on a dad switch, but that doesn't mean moms or dads. It means families. And Debs, you just did a lovely job of framing that in a way that really helps people see that it has to be across all of these different supports and across these different family structures that we see. We do need to shift gears. Thanks everybody for the great stuff that's happening already in the community around Edinburgh and the screening that's happening. And our hope is that we could catalyze more. And we're going to shift gears here and have you go ahead, Marilyn, and tee up Cindy's slides and have a conversation now very specifically about our Indigenous populations. So you want to go ahead and start us off on that conversation.
Hello, everyone. I don't know if you can see me. I can't see me, but
yeah, you're good.
hopefully you can. Okay, wonderful. I'm Cindy Gamble. I'm a tribal community health consultant with the American Indian Health Commission. I'm Tlingit. My homelands are in Southeast Alaska, but I now live in Olympia, Washington. And this has been a great conversation. And in my long career, I've done a lot of work with moms and kids and so love this topic and love the conversation, the questions, and they're all important. And I think I just wanted to weigh in on Kyle on your question because it's lack of funding is something that I'm going to talk about too. And Debs, I really loved your answer. Thank you. So one of the things that I went too soon here. One of the things that I hope that you leave this session with, and it's just going to be very quick, a very quick overview, is really why we tell people, please recognize the need for tribally led solutions. And hopefully we'll get to that. So Deb's already and Annie both said this. The highest risk factor for maternal mortality in Washington State is to be American Indian and Alaska Native. And this was true that it was higher than any other race or ethnicity in the 2019, in the 2023, and in the 2025 reports. So even though we are a very small population, our rates are high and the disparities are very profound, and it gets our attention. And so this particular statistic definitely got our our attention and the tribal leaders' attention, but we have to put it in the context of our whole experience. And it is just something. There are enormous health disparities for American Indian and Alaska Natives in many states, and that includes Washington State. And so when you look at this measure of health through chronic disease incidents, you will see that American Indian, Alaska Native in orange have higher incidences of all of these diseases except for Alzheimer's disease, which is pretty concerning, of course, if you're American Indian or Alaska Native. Why is that? And we believe that we do know the answer to that. For us, it is all about our experience, about the 500 years of historical trauma, which led to incidents of intergenerational trauma and to the ongoing racism and discrimination that occurs today and definitely impacts self-medication. So people misusing alcohol, tobacco, marijuana, illegal drugs, all of that happens, and it has, again, that profound impact on our health, on our mental, physical, emotional, and spiritual health, which then plays out in all those disparities and definitely plays out in maternal mortality because that is such a special and important time of a woman, the infant she's carrying, and the family's life, the father's life also. So we were very concerned when the DOH folks came to American Indian Health Commission's annual meeting and told us these statistics, and the tribal leaders said, well, what can we do about it? Well, this was in December of 2019, and we remember what happened in early 2020 is when COVID hit. So it took some time for us to get a small pot of money to hold at least one listening session with American Indian Alaska Natives around the issue of maternal mortality. And, knowing all the things we know about all the health disparities, and those were just physical health disparities, we can look at behavioral health, emotional health, housing, all of those things. American Indian Alaska Natives have disparities. And so we knew that we were not going to go into our communities and talk about maternal death. We were going to go into our communities and talk about the concerns about maternal health, the health of Native pregnant, birthing, and postpartum women and people. And so that was our approach. The problem was, and we were very excited about it, to go into community and talk to people and hear what they have to say, and then bring all of the thoughts and wisdom of community into the tribal leadership, who would then shape the recommendations to be put into the addendum to the report. So we were very excited to go into community and do on site. The problem was that COVID hit and the tribes were closed. So we had to do virtual meetings, which we were very nervous about. After a year or two, workers, leaders were very used to zooming around, but we were very concerned about community. Were they as comfortable and proficient with doing video things? But they were. And so it was really great. We had our first meeting, and instead of having just one virtual statewide meeting, we ended up having 5, just because they were well received and popular. We had men and women, we had the women of childbearing age, we had youth and grandparents, we had dads. One of our favorite stories was of a young man. He came to I don't know, second or third, fourth session, but he said, yeah, my partner told me that I might be very interested in attending this. And so when he turned on his camera to speak to us, we realized he was at the river fishing and had his fishing pole set up, but it meant a lot to him. And so he was there with us to put in his his 2 cents into what the needs were. So we just really loved that. We ended up, as I said, having the five community um, gatherings, and then we ended up having five um, leadership gatherings, which then ended up into having that was our phase one, which ended up the addendum in the 2023 report. And you see that those 10 gatherings ended up with 7 recommendations for the 2023 maternal mortality review report to the legislature. We were lucky enough to secure funding again for a phase 2. And in those 2 years, and again, it's a small pot of money, so we're not able to go and visit every tribe. We hope for future funding so that we can go to visit every tribe and urban Indian community. But we ended up having 6 visits where, yes, we were able to go into community, talk and listen to people face to face, and just really hear what was on their hearts and minds. And it was just really important. And those visits ended up with 14 recommendations for the 2025 report to the legislature. And so we were really pleased about that. So the 21 total recommendations, these aren't the recommendations. And I forgot to note when I started. At what time did I start? So I don't go over.
You're good. About maybe 10 more minutes.
Okay, perfect. So in overall, the recommendations, I guess they developed the recommendations, and so it might be duplicative to say that the recommendations were tribal and urban Indian health leader developed and led. But it's really important to say that because this is an approach and a philosophy of the American Indian Health Commission, a strong belief that if we are going to make a difference for our communities, the work has to be tribally led. And that means, whatever that means, that can mean that the tribe wants to lead the work themselves. It may mean that they are going to call in and want to work with specific partners, but they get to make the decision, and that's really important. And we love that it is in the 2025 report that Debs and Annie just talked about, because it is important that our partners and allies recognize this, that when funding opportunities come, sometimes well, all the time, we believe it needs to go to the tribes to make the decision instead of having other people make decisions about how work should be done for the tribes. The work needs to be the recommendations. Definitely it needs to be trauma informed, which means for us that they are healing informed. All of our work really has to have a healing component. Well, what does that mean? Well, a lot of the recommendations from the community were all about families. It wasn't just about the mother, even though that was our title, about the health of Native pregnant, birthing, and postpartum women and people. The communities came and said, these are recommendations for families, because there's that strong recognition of the importance of the family as a unit. And so the recommendations were all about the mom and dad and the family, the strength of the family. Healing informed also refers to the fact that of the workforce that we need people who look like us and understand us, who are the people that we're working with. It has to do about the data, how the data is collected, what data is collected, how the data is shared, because there has been a lot of damage about American Indian, Alaska Native people when we have disparities like this. And so it's really hard to live in that environment when you're told these things, right? And so there are many examples of being healing informed, but the recommendations really need to take that into consideration. One of the things I really loved and was unexpected for us in the first addendum, that the tribal leaders put in a recommendation around food sovereignty. And food is just so important, having nutrient dense food. One of the things that we found out is with today's modern food and processed food, the availability of fast food, it is, we all know that's nutrient poor. But if moms aren't eating nutrient dense food that are going to feed the baby and herself, the baby can actually be small and have smaller organs and everything. So nutrition is just so important for both mom and the child that she's carrying. And part of healing informed is really understanding the impacts of historical and intergenerational trauma. And that is we could have a whole session just on talking about that and all the myths and misunderstandings that people have about modern American Indian and Alaska Natives. For instance, thinking that Indian health services and tribal clinics are 100% fully funded. Nothing could be further from the truth. Even the government's own Government Accountability Office says that tribes are only, IHS is only funded at about 40% of need. Some people say even less, at 30, 38, 39, but we'll round up to 40. And so that is something that also happens. And another myth is that there is no longer in our newly enlightened age that racism and discrimination just doesn't exist for American Indians, Alaska Natives. The tribes have it all. They have casinos, they have this, they have that. They're fully funded. And again, nothing could be further from the truth. Yes, it's true that tribes are having the potential and opportunity to have opportunities for building fiscal strength in their communities, such as casinos. But casinos actually employ a lot of people, and they're not just all tribal people. Tribes are good neighbors, and they're some of the biggest employers in their communities. But there's this misunderstanding that racism does not continue to exist and have an impact on the people who are going in to see doctors, to see behavioral health people. And so it's also very important that we uphold tribal sovereignty and uphold data sovereignty. So I was going to say thank you. So do I have like 5 minutes left?
So
Anne or Marilyn?
can you do about 3?
Okay, 3. So I'm just going to go through as many of the recommendations as I can. The number one priority is to reduce Native maternal mortality until the disparity is eliminated. A lot of times the healthy people recommendations are all incremental, and we just want it to be over and done. And so we want to have that goal. And so we know that it means, as Debs and Annie talked about in the big report, that means a culturally appropriate engagement and education that is given and offered to people. That includes the providers, the community people themselves. Just the questions about different types of drugs and things that have been in the chat. Yes, there still is a lot of education that needs to happen with our people. Tribal-led data needs assessment. Again, we talked a little bit about that. And again, the issues about historical trauma, it really does impact us today. We are a oral tradition people. We did not have written books and things, so we carry our history in our memories, in our hearts, and our spirits, and so we feel those too. So the need for improved and expanded access for culturally relevant services, using the 7-generation principles. Again, we don't work on this 12-month calendar of getting things done. We look at things through generations. What happens in this generation and how long it takes to do things. And that's just really important for people to understand when they're working with tribes. Again, the tribal-led workforce and having people, not only people, non-native people and non-tribal people in their organization, to hire tribal members so that the tribal people that they do come in, they have someone to offer. So it's not just for developing people to work at tribes, but tribal people to work all across the workforce. And again, I just love that tribal-led nutrition planning and project development, such as food sovereignty and the first foods. And really quickly, again, the 14, the recommendations. The one is that we really want there to be acknowledgement that maternal mortality of American Indian, Alaska Native birthing people is a crisis. The disparities are persistent, and we really need to do something about it. And so, Deb's the QR code that Debs has and the link she put on to the 2025 report. At the very end of that report is our addendum. And so I just really encourage you, if you're interested, to look. And I'm just going to really quickly show you here. There's the 14. But I also wanted to show you if people had questions on what is historical trauma, what is intergenerational trauma, what is ongoing racism. So historical trauma, depopulation, a lot of people don't think about how tens and hundreds of thousands of people died just right away. And what a shock that was to have their leaders, their relatives, their children die. Intergenerational trauma. One example is boarding schools. When children were taken away from their parents and put in boarding schools, not allowed to speak their language, their hair was cut. You know, those sort of things, they break that sacred bond between both parents, the parents and their children, so the culture and the people can go on. That is traumatic. And ongoing racism to this day. In the 50s, they had termination policies. And one thing that I don't know if a lot of people know about, the Indian Health Service actually sterilized they figure about 25% of American Indian Alaska Native women of childbearing age without their knowledge or consent. So these are examples of some of the racism and trauma. And then, of course, missing and murdered Indigenous women and people continues to today. So thank you for that little extra time. And again, I hope that you will go to the, whoops, anyhow, goodness, Chief, thank you.
Thank you, Cindy.
And
I just want people to recognize that we intentionally kind of grounded this topic with the big report and wanted to do just a little tiny glimpse of the broader context around our Indigenous populations, but very, very opportunistic now that this has very naturally set up a follow-up for us to potentially do a provider learning series on the unique needs of parenting in Indian country and the issues that Cindy, you just went through very, very quickly that we could really take a whole hour and a half talking about. And so I don't want people to think that that was an afterthought. It absolutely is not. And so thank you, Cindy, for opening up that door. And the hope is that we will be able to walk through it more comprehensively in a provider learning series. We have many tribes now that we have worked with, really intentionally partnering with tribes with the Fatherhood Council over the last few years, that are really excited about presenting and talking to you all about the unique needs of dads and having a panel of dads from Indian country. So thank you to all three of you. And I'd love to give you each just a minute to have your last thoughts. So what do you want this diverse group of people to walk away from today thinking about? And maybe we'll just go in the same order as we did with the presentation. Debs, you want to start us off?
Sure, thank you. And I mean, we're seeing a lot of it in the chat already, but I want you to be able to take away how can you work together on what's most important and relevant to you that's related to this report. And it looks like people are already doing that. And also, what is your understanding of maternal mortality from the report? How can you raise awareness, even if it's just talking to people in your own community?
Annie?
Yeah, to kind of go along with Deb's, I'll take the approach of kind of summarizing what the findings really showed for me, which is the importance of the postpartum period. So really trying to collaborate to ensure that mothers are followed up with after they've given birth, because it's such an important time, and like considering that in relation to some of the disparities we talked about. So postpartum for rural individuals, postpartum for our different racial ethnic disparity groups. So stuff like that.
Thank you. And Cindy, last words, last presenter.
thank you, Anne. Well, I'll just say that, we live in a society where just money and profit is worshipped. And so it is very difficult to put the money into prevention where we need it. And I came today to speak on behalf of American Indian Alaska Native people and how we need to have tribally led solutions. But really, that thinking can go across everyone to every other race and ethnicity for different rural versus urban, for different neighborhoods. I think we're all unique, and this efficiency of making profit by one size fits all just doesn't work when we're trying to make people healthy and really think about what works for our community. So I just think even though it is harder to do it, it's good work. It's hard work, it's challenging work to break it down and to go and recognize the unique needs for everyone. But I think that is where we're going to make a really big difference with all of those recommendations, those wonderful recommendations in the report and all the work we do. We need to look at everyone as beautiful individuals that they are and how we really want to be healthy, and we all have a part in that. So thank you.
Oh, thank you. That was lovely. And Amy, thank you for your quote that you posted from Abigail Echo Hawk of an Indian Health Institute. Don't come to us because we have the problem. Come to us because we have the answers. And I think that is, I mean, it's so powerful within our Indigenous communities, but it's very powerful across all of our communities as well. And I think that's part of the awareness raising around the role for fathers and bringing dads back into this at the close to say, we need their voices at all of these tables to put that mantle and to turn on that switch in people's minds. So thank you so much. This has been an amazing conversation. Thank you for all you put into it. Just a reminder, please do the evaluation that's in the chat. Thank you, thank you, thank you to Marilyn Gisser and all the folks from the Department of Children, Youth, and Families that helped that are keeping this work and holding this work up and putting all of the back shop work into making it happen. So appreciate you, Marilyn, and others that are still on the call. And just another quick little nod to Jose Romo Ramirez, who I think has had to sign off, but Jose really had this idea about a year ago. What are we doing to look at maternal mortality through the lens of father fusion? So just a shout out to him as well. We are now off until February, so you'll have the next posting soon of the next provider learning series, and two of those presenters were in the room today. Thank you, Bridget and Jill from the Division of Child Support. We're going to talk again about the great work that they do in February. So you'll be seeing that coming to a computer screen near you in an invite from the Washington Fatherhood Council. So thanks, everybody. We so appreciate delving into this difficult topic and thinking about it in terms of what can we do as a collective to lift up these families that are going through this horrendous experience. And Debs and Annie and Cindy, if you want to stay on, I don't know if you're back to back here, but we might be able to pull some of the eval results. No one's ready to do that, but we could if you're interested. Thanks, everybody, for joining us. See you next time.
Thank you.
Lots and lots of love coming through the chat, you guys. This has been really, really positively received. February 19th.
Thank you.
Thanks, everybody. And yes, this will be posted on the website, but probably not as quickly as you're used to. And yes, the slides will be there. So hang tight with us. Jennifer, is that your question as you head out the door? Jennifer, did you have a question as you head out the door? Jennifer, you're cut off on my screen, sorry. Yes, okay. We try and post them as quickly as we can, but because the website is still in transition, it's going to take a little longer. But you've gotten links to the report from Debs a couple times in the chat. So please download that and really that'll give you all kinds of ideas of intersectionality and points of engagement. Thanks, everybody. Yes, we do want to advocate for dads. Thank you, Jennifer.
Bye, Anne. Good to see you.
Bye. Good to see you. So Marilyn, we didn't talk about this and you may not feel ready, but if you're comfortable jumping into the eval screen, sometimes at this point, we've got some things we could share with the presenters.
I think you've got some other folks still on the Zoom.
I'm working on it.
Okay. And is this still being recorded?
No, we'll turn it off.